My name is Nasim and my last name is Shahbazi. That's the way it's pronounced here. However, the actual pronunciation is Shahbazi. For the patients that I see in Imperial County, the important message I have is that the health of any patient is a partnership. It's a partnership between the physician, the whole medical team, and the patient, and sometimes the family. So the outcome will depend on the effort of the medical team and also how much the patient is participating in the care of themselves. So attending clinic visits, doing blood work as recommended, bringing the medications that are taken to the visit, and following the recommendations and keeping the discussion open with their physician, asking questions, why you're changing my medication, why my blood pressure is not under control, why my kidney function is getting worse, what can I do to make it better, and be active and be a participant in their health. And then we can have the best outcome possible. And it's always good to have the family support if we can have it, and obviously it's not always available for all patients, but if we can get support from family, that will be very helpful. The ways that physicians can help patients to get motivated, I think is one part at least giving more information about their health, about the things that may happen in the future, and not necessarily they have to happen if we act now. So, for example, when I get a patient in early stage of a kidney disease, they are diabetic, I tell them that if we act now, then 10 years from now, you're not going to be on dialysis. We can postpone it to maybe 20 years, maybe 30 years, maybe not ever. So I think if the patient really understands the outcome that can happen in the future and what we do now can prevent that outcome and the bad things that may happen in the future, they get motivated. And that's one of the strategies I use, just to give more information to them and tell them, okay, in this era, we have tools that we can use to help. Something I have learned from my patients over the last many years that I have been practicing medicine that I think has affected me and made me a better person is learning how to be strong and resilient, dealing with severe and very sometimes difficult diseases to treat. Patients with kidney disease, they sometimes, not all of them obviously, sometimes they go through a lot of hard time, and I have seen patients that are going through this hard time with hope and how they have been successful in their journey. Their strength and their resilience sometimes is inspiring. And I think I'm still trying to learn that from them. But the thing that the patient may experience when they're labeled with CKD actually depends on the degree of the dysfunction of their kidneys and many other factors. Each patient is unique. The thing is that kidney disease at the beginning may not have any symptoms. It's something that usually picked up on blood work by family doctors and primary care providers, and that's where the patient is sent or gets sent to a nephrologist. At that point, they may not feel anything. And the symptoms of kidney dysfunction usually happen when the kidney dysfunction is advanced, and patient may start having nausea, vomiting, lack of energy, lack of appetite, getting swollen, and many other symptoms. However, it depends on the cause for the kidney dysfunction and many other factors. Some patients with early stage of kidney disease may come with significant swelling and shortness of breath because they have a lot of protein in their urine and they become symptomatic. So it's different in each patient, but in general, most often at the beginning is just picked on the blood work. One of the diets that has been shown in general, not in patients with kidney disease, in general it's good for people, is Mediterranean diet. And then the question about plant-based diet, again, I don't think we have any firm conclusion. Although in patients with kidney disease, we recommend them to be on a low protein diet, or at least not to be on a very high protein diet. And again, it depends on, it might be different in different patients. And plant-based diet and the protein from plants, maybe it's better than from the animal source. Again, we don't have a conclusion and a firm idea about that. The question about over-the-counter medication, that's a very good question. Some of the over-the-counter medications can have bad consequences in patients with chronic kidney disease, especially advanced kidney disease. For example, a class of medication which we call them NSAIDs, like ibuprofen, Advil, naproxen, Aleve. In some patients, if especially their body is dry, their volume depleted, and they're taking this medication, and at the same time their blood pressure is low, it can have a bad hit on their kidneys and cause an acute injury on their kidneys. So we tell the patient, try to avoid this class of medication, which they usually take it for ache and pain, and we should either limit the use or not to use, or take some Tylenol instead. And again, it's different in different patients, depends on their underlying comorbidities, their stage of kidney function, other medication they're on, their blood pressure, their fluid intake, their fluid loss. So it's very important that they talk to their physician, either their primary care provider or their nephrologist, and see if they're allowed to take this medication, how much, and maybe they should avoid it altogether. And the question about the other over-the-counter medications, I always tell my patients that I'm not a big fan of those, especially all these extra supplements that we don't have any proven benefits scientifically. There is no study about them, and many times we even don't know what is in that bottle of the pill that is sold as like help with this or help with that. We even don't know the ingredients. So personally, I tell the patients that I'm not totally against it, but I don't recommend it unless there is something that we exactly know what's the function of that medication, if the patient actually gets any benefit from it. And besides, our patients, especially kidney patients, they're on many medications. Usually they need medication for their diabetes, for their blood pressure, for heart problem. And then on top of that, some of the supplements is an add-on medication that may not have any benefit. Again, we don't really know about them. So if a patient reaches end-stage renal disease to the point that nephrologists think the patient needs some sort of renal replacement therapy, we have different options. So the best option obviously is transplant, and the best one, if we have a live donor, that's something that we really encourage. But if transplant is not something that we can do it in a timely manner, or there is no live donor, then the option is dialysis, that we have two different types. Either hemodialysis, which is through the blood, or peritoneal dialysis, which is through the abdomen or belly. They both clean the blood from the toxins and maintain the fluid balance and electrolyte balance. We usually recommend peritoneal dialysis as the modality of choice for most of our patients, although we understand that it's not possible for all, and some patients cannot go on peritoneal dialysis. Peritoneal dialysis gives the opportunity to the patient to do dialysis at home and not to travel to a dialysis facility, which is usually 3 times a week and every time 4 hours for hemodialysis. Peritoneal dialysis is done at home. It can be done during the day. It can be done at night with a machine that does it. And patients can travel. They can travel with their bags of fluid, with the dialysis machine. And also, they're usually more liberal in their diet. Proton dialysis is more smooth because it's done every day, and it's a bit more gentle on the heart, as the fluid removal on proton dialysis is done slowly and over a period of 12 hours and sometimes over 24 hours. In hemodialysis, it's done over 4 hours, which is a bit quick for our body to tolerate it. So if a patient can go on this modality, we would encourage patients to go on home modality, which proton dialysis is one of them, although we have home hemodialysis, which is also another good modality, which can be again done at home. And if not, then the option is hemodialysis in center, which is the one that is done through the blood. So the question about work on hemodialysis and proton dialysis always come up when we are transitioning from kidney disease, CKD, toward end-stage renal disease. And I have to say that dialysis is a big change in our life. It needs a commitment to do either dialysis at home or go to the dialysis facility and do dialysis 3 times a week or sometimes more. So there is a change, obviously. However, patients on proton dialysis and hemodialysis, they can continue to work. It depends what type of job they have, how is their health condition, how is their energy, if they are getting to any complications with dialysis. Assuming that everything is going well, patients can continue to work. And we usually see that patients on peritoneal dialysis, they continue to work longer and they have a life which is more close to their previous life compared to patients on hemodialysis. And the difference is, again, because peritoneal dialysis is done at home.